Dr. Thomure is one of our own, MD grad, 87 here at Mizzou. Went on to Georgetown for OBGYN residency, and then followed up with a fellowship in reproductive endocrinology and infertility at WashU. From there, he went over to St. Louis University. He was professor of OBGYN, and became director of the Reproductive Endocrinology and Infertility program. Specializes in infertility and polycystic ovarian syndrome. And he's also the residency program director, and there he is now.
Thank you very much. All right, this is great to be back. It is great to see old friends. Roy, how you doing? This is a lot more fun than I thought it was going to be. And I apologize, I don't have pictures of like St. Louis University. Everybody seems to have pictures of where they are. So I apologize for not having a picture of St. Louis University, but I got some pictures for you. I'm going to talk about an infertility evaluation. I figure everybody knows somebody who's had trouble getting pregnant. So hopefully we'll be able to walk away with some advice that we can maybe give them if they ask us questions. And this goes back all the way back to the Egyptians. Watermelon, which was pounded and mixed with the milk of a woman who had given birth to a male child, was administered to the woman that they thought was infertile. If she vomited, she was considered to be able to get pregnant. If she burped, she was infertile. So, and they also used hippopotamus dung, and the woman's vagina was fumigated with hippopotamus dung. If she defecated, urinated, or passed flatus, she was fertile. If she didn't, she was infertile. So through the years, there's been a lot of infertility type myths. I don't know if you guys recognize this. This is Tulum, Mexico. Beautiful, beautiful place. I love to scuba dive, and this is one of the areas I like to go scuba diving. That is I took a tour there once, and they said that this was actually a fertility type temple, and these were like the legs of the fertility goddess, and right up there, I don't know why there would be 3 doors for an introitus though, but it's where you were supposed to offer gifts to the fertility gods. But I went back again a second time, and the tour guide gave a completely different story. So I don't know if it's an infertility temple or not. I had the opportunity to go to Thailand a couple of times, and actually went to an infertility type temple where they had a floating nun, and the highlight of the trip was getting to have your picture taken to the big wooden penis right here. So I don't have pictures of St. Louis University, but I have pictures of wooden penises. So you got to get your picture taken next to the penis, and on your way out they gave you little keychains for good luck. So little penis keychains. Okay. So modern day myths are telling the patients to relax. And there may be a little bit of truth to this. Telling patients they have to put their bottoms up on a pillow after they have sex. Telling guys that they have to wear boxer shorts. The tilted uterus syndrome. For some reason, people tell patients if their uterus points backwards rather than forwards, they're going to not be able to get pregnant. Geritol, Robitussin, Synthroid, these are all things that people have tried that really have not worked. And coital position, there's actually a book out that one of my patients gave me that stated that if you have relations in the standard missionary, you're more likely to get a male. But if you have it reversed, and I don't want to use the wrong terminology here, use your imaginations. You're more likely to get a female. Maybe that is what the myth is. So what I'm going to talk about is how we do infertility without going to the high-cost in vitro fertilization, and kind of go through the workup a little bit with you. The definitions: infertility is 1 year of unprotected coitus without conception. And you have to take into consideration that this is 1 year of a good trying, of a good effort. I've got patients that come in, and for some reason, internal medicine residents, as soon as you hit your internal medicine residency, you stop having sex. Internal medicine residents say they have relations maybe one or every 2 months. So you don't really need to see a specialist to figure out why that is. Fecundability and fecundity. Fecundability is the ability to get pregnant in 1 menstrual cycle, and fecundity is the ability to actually have a baby in 1 menstrual cycle. And it's seen at about 10 to 20% of couples, probably on the higher end, more like 1 in 5. And there's a big belief that infertility, it's getting worse with time, but international studies are consistent with what we see here in the United States, that there really isn't an increased trend in infertility. It's just that this infertility epidemic is more due to population demographic, postponement of marriage and career and things like that. So there's really not any big increase in infertility. How long does it typically take women to conceive? Guttmacher looked at 5,000 women in England and the United States between 46 and 56, and the data is still consistently the same. After 3 months, about 50% of women are going to be pregnant. After about 6 months, 75% are going to be pregnant, and after a year, about 85%. So that's where we get the 1 year of unprotected intercourse, is that number right there. And if you wait another year, up to 93% of patients should be pregnant. Normal reproductive efficiency is not really efficient in people. Normal cycle averages about 20%, which if I remember correctly, baboons are closer to 80%. So I don't know why humans are so much less than than primates are. Coital frequency, how frequently should we tell our couples or our patients to have relations? In 53, these two investigators, McLeod and Gold, said that 3 times a week gives the best efficiency for conception. And that kind of makes sense. If you think about it, the egg has about 12 to 24 hours to be fertilized after ovulation. And the sperm can retain the capacity to fertilize for up to 3 to 5 days. So we tell patients coitus about 2 to 3 times a week provides the best efficiency. And it kind of relieves the guys a little bit, because some guys get kind of freaked out when you have to have performed relations and things like that. So if they know if they can have about 3 times a week that they're okay, it helps them to relax a little bit more. And timing, when should we be telling our patients to have relations? The best time seems to be about 1 to 2 days before they ovulate. And we'll go over how we tell patients if they're ovulating or not. 3 days before ovulation, about 15% of couples will get pregnant. On the day of, about 12%. And if they wait a day or 2 after, near 0, which makes sense since the egg only has about 12 to 24 hours to be fertilized. Other myths, like I said, coital position doesn't mean anything. Presence or absence of a female orgasm, the female position after male ejaculation, don't have anything to do with people getting pregnant. Lubrication, there's no real evidence that lubricants decrease infertility, but possibly they may decrease the motility of the sperm. And the culprits are KY jelly, Astroglide, Touch, olive oil, and saliva. And believe it or not, mineral oil and canola oil is what is recommended. Canola oil and not olive oil, for some reason, doesn't mess up the fertility. And you can imagine some of the eyebrows that are raised when I tell patients to go get a bottle of canola oil. Psychological stress and infertility. This was one that we kind of didn't really think had anything to do with anything with infertility, because if they were ovulating, we thought, well, it shouldn't really have any effect. But there have actually been some studies that have been done recently where LaPayne did this mini international neuropsychiatric interview and showed that 40% of the patients that took this test reached or were actually met the criteria for a psychiatric disorder, with anxiety and depression being the most common. And Freeman showed that with in vitro fertilization patients that infertility was the most upsetting experience that they had ever experienced in their lives. So there's a lot of stress and a lot of anxiety associated with infertility. Most people think that the dropout rates for infertility clinics are because of the doctor says, we can't do anything for you, or because they can't afford it. But there's a lot of studies that show that patients that do have infertility coverage, that a lot of them do drop out just because of depression and the psychological burden. A couple of randomized controlled trials looked at this. DeLiz looked at 60 IVF couples, and they noted that people just getting routine care, and granted this data is a little bit older, our IVF success rates are much better now, but noted that 17% of the couples that had nothing, no kind of intervention, were getting pregnant, as opposed to people who were getting this counseling service model, where there was a nurse that would call the patients every day. They would go to all the procedures with them, go to their egg extraction, go to their embryo transfer, and they found that group had a 43% pregnancy rate. And another study looked at 184 patients and split them up into 3 groups, where the routine group was about 20%, and groups that had like 10 sessions of mind and body therapy or support groups, 55% and 54% pregnancy rate. So there may be something there may be something to do with stress and anxiety for infertility as opposed to just keeping them from ovulating. Age of women, it drops off pretty fast once they get into their late 20s, and the miscarriage rate increases. So that's the deal with women, but it's not quite the same with guys. Pregnancy rates for men greater than 50 years old have been demonstrated to be 28 to 38% lower than guys that are 30 years old. And there was a British study that showed that guys over 45 years old took 5 times longer to conceive. On the other hand, they've looked at in vitro fertilization data with a donor egg and showed that it didn't matter how old the guy was. 24 to 64, they all had the same fertility rate. And it's probably not that big of a deal before the age of 50, since there's not a lot of guys greater than the age of 50 that are coming for fertility care. So it may not be that significant after all. Smoking. We tell our patients that they need to quit smoking, and there very well may be smoking may be contributing to infertility, but it's not until you get up to smoking over a pack a day. And the contents of the smoke have something to do with changing the estrogen components around. So smoking may have something to do with it. Alcohol. There are some observational studies that report moderate 3 to 4 drinks per week, or heavy greater than 14 weeks or drinks per week may delay pregnancy, but there's others that have shown absolutely no difference in looking at alcohol use and ovulatory function or infertility. And in men, moderate alcohol intake does not appear to really be associated with a decreased fertility. Looking at caffeine, same thing, nothing until you get over 300 milligrams of caffeine a day. Not all studies show this, nothing really demonstrated in men. And to give you an idea what 300 milligrams of caffeine would be, a typical 12-ounce beverage of these things, like Pepsi One, is 55 milligrams. Where's Mountain Dew? Do I have Mountain Dew on here? Mountain Dew, 55. But what's interesting, look at Starbucks. 375 and 550 milligrams of caffeine. So maybe that's why they have a Starbucks on every street corner in downtown Seattle. There's a lot of caffeine in Starbucks. Weight. Overweight being defined as a BMI of greater than 25. That should be 29.9 kilograms. And obesity of over 30 kilograms. A BMI of 27 is associated with anovulation and insulin resistance. And what they're finding out in women with like polycystic ovarian syndrome and with the greater weight, they have hyperinsulinemia, and the high levels of insulin stimulate insulin-like growth factors on the ovary, making more androgens. So these are the women that are not ovulating. So there's something to do with weight there. And on the other hand, women with a BMI of less than 17 have hypothalamic amenorrhea. These are like the runners and women that have low body fat. BMI less than 17, they're not ovulating. They're not making GnRH, gonadotropin releasing hormone, no FSH, so they're not ovulating. So there is something to do with weight. And looking at guys, there's conflicting results on the effect of obesity and semen parameters, and no real data on infertility or showing that overweight guys are infertile. Substance abuse. Marijuana has been said to inhibit the secretion of GnRH and therefore stop ovulation. Cocaine, a guy that was in my fellowship 2 years ahead of me did a study where he saw that cocaine impaired spermatogenesis. Excessive alcohol, like I said, may do something, but the recommendations are, we try to use this as an opportunity to tell patients to stop smoking and to be at a healthy BMI, limit alcohol to 4 fewer drinks per week, and limit the caffeine intake. But the bottom line is there are no randomized controlled trials showing that any lifestyle modification helps these patients at all. So when do we evaluate? We typically evaluate couples after they've been trying for 12 months, but we can do it a lot more quickly if, say for instance, they're under the age of 35. If they have irregular menses or infrequent menses, they're probably not ovulating. So there's no point in telling a couple to go have relations if we don't think they're ovulating. History of pelvic infections or endometriosis if we think something's anatomically wrong with the uterus and the tubes. And a known or suspected male factor, we would need to evaluate them much more quickly. What are the causes of infertility? Ovulation, 15%. The big ones seem to be male factor and tubal factor, about 35% each. This unexplained may be a little bit higher than 10%, and unusual is causes that don't fit into any of those, and I can't think of what they would be at the top of my head. So what do I ask for a history? How long have you been infertile? I've had people come in and say they've been trying for a month. I'm like, well, you know, you need to go out and try a little bit harder than a month. Coital frequency, like I said, the poor internal medicine residents who get to have sex 6 times a year, probably not gonna help them get pregnant. Menstrual history, are they having regular cycles? If they're having regular cycles, it implies that they're ovulating regularly. Are they passing clots? Typically, you see that with anovulation. If they get PMS-like symptoms, breast soreness, things like that, those are all signs that they're probably ovulating. History of sexually transmitted diseases, that can really mess up the tubes. Gonorrhea and chlamydia are killers. Lubrication, like I mentioned before. Prior surgeries, anything going on with the cervix, obviously not a hysterectomy, but hysteroscopy, things like that. And anything, issues with the thyroid gland, galactorrhea, hirsutism, pain with intercourse. Pain with intercourse would be associated with endometriosis. So physical exam, typical physical exam, paying attention to thyroid, breast secretions, looking for galactorrhea, and signs of androgen excess. This acanthosis nigricans, we check the back of the neck, and that's indicative of the hyperinsulinemia, which could definitely lead to anovulation. The way that I was trained at WashU, where I did my fellowship, the guy that taught me, excellent teacher, kept everything very, very, very simple so that anyone will be able to remember this. And it's the COST system, where C stands for cervix, O stands for ovulation, S for sperm, and T for tubes. And this is the little chart that we had, and we'll start with the cervix and kind of go over the different tests that we could do. The first one is a postcoital test that was first described in the year after the Civil War ended. So this thing has been around for a long time, by Dr. Sims. And anybody, if there's any OBGYNs in the crowd, Dr. Sims was famous for a lot of retractors and a lot of the procedures that we use. But the problem with this postcoital test is there's no standardization of what's normal. I've heard, if you look under a microscope, oh, the test is where you have the patients have sexual relations, and they wait a couple of hours and come back into the office, and we take the cervical mucus and put it on a microscope slide, and if there's supposedly 5 motile sperm per high power field or 10, it says that they're okay. So no one really knows what the number of motile sperm should be or how long they should wait. And if you look at the actual literature, and plus patients hate this test. Patients hate coming in after they have sexual relations. And I remember when I used to do these tests, I told this one patient that the term is hostile cervical mucus. And I remember telling her that her mucus was hostile, and she later told me that she went and cried for a week because she thought she was killing her husband's sperm, and she felt terrible about it and really guilty. So it's a dumb test is the bottom line. And people still use it. Sensitivity and specificity, if you add them up, they should be about 150 to signify a good test. It's not supported. If you look at the sensitivity and specificity and add them up, they don't quite reach 150. And if you look at an ROC curve, which a perfect test would kind of go up along here, hug the x-axis and go along there, whereas a coin toss is this right here. That's the postcoital test. So I could flip a coin and give them about the same information as I can with this test. So the bottom line is the postcoital test has no proven benefits in the evaluation of an infertile couple, but people still do it and patients still come in requesting it. And I was actually called a quack because I told a patient that I didn't think it would be a good idea to get this test since it's not going to give her any information. So she went and found somebody that would do it for her. Anti-sperm antibodies. Anti-sperm antibodies, like it sounds, are antibodies that stick on sperm. They can be in the guy, they can be in the woman. And there was an article that was published that said that there is sufficient evidence to support the hypothesis that anti-sperm antibodies play a role in selected couples with unexplained infertility. But when you look at the article, it says prevalence and magnitude remains controversial. Routine screening in couples with unexplained infertility is limited because there's no accepted consensus about which one to use. There's no relationship, and it needs to be sought. and needs to be standardized. So the bottom line is, why would I get this test if it's not going to change what I do and it's not going to help the couple? So I'm kind of knocking off, the laundry list for our infertility workup is getting less and less the more that we know. Ovulation. Ovulation, they have LH predictor kits that you can buy at Walgreens or Walmart, and they accurately predict ovulation greater than 90% of the time. And there is a lot of variation with the kits. There's a lot of cheaper kits out there, and Consumer Report actually did a review of ovulation predictor kits, and it was dead on with what my patients said. There's one kit called Answer, which is not your answer. It does not tell you anything. The best one is probably one called Clear Blue Easy, and they give you a little smiley face now. So if you're going to ovulate, you get a smiley face. And there's another one that has an egg, an electronic one. The electronic ones are no better than the just regular urinate on a stick one. So you get different smiley faces and happy eggs and stuff like that when you're going to ovulate. Basal body temperature chart. Believe it or not, we still use these. They're inexpensive, and they can be used when starting treatment, but the thing is they're retrospective. You can't take your temperature every morning and know when the best time to have sexual relations, because once the temperature's gone up, the egg has probably already had its 12 to 24-hour lifespan. Compliance problems, patients don't want to wake up in the morning and take their temperature. They don't want to be reminded that they're infertile every time they get up in the morning. And this is pretty much what it looks like. You see two phases, which is what they call it biphasic. Right here would be the first part of the cycle, ovulation, and the second part of the cycle. So what I teach my residents is if you can take a pen and cover up the vast majority of the points there and the vast majority of the points up there and have two separate lines, then they're probably ovulatory. We have them take it the first thing in the morning before they get out of bed, before they go pee, before they do anything else, and it's a really useful tool for helping us document whether or not our treatment is working. Mid-luteal progesterone. This used to be kind of like a gold standard, but I'm kind of getting away from it, because when you get values that are kind of like inconclusive, you don't know what to do. Some of the study or the labs from Smith or from Quest or LabCorp will say 3 is ovulatory, but there are studies that show that they should be greater than 10 in non-stimulated cycles or greater than 15 if you're using medication to be able to sustain a pregnancy. We get it a week after ovulation, but the thing is it's pulsatile. So if I get it at the bottom of a pulse, I don't know, does that mean she's not ovulating, or am I getting it at the bottom of the pulse? So I find it confuses me more than it helps me, so I'm getting away from using that. So other things that we do to figure out if a patient is ovulating is we use ultrasound, but a follicle looks the same to me as a corpus luteum. So I can't tell which is pre-ovulatory and which is post-ovulatory, so it really doesn't help me. The gold standard used to be an endometrial biopsy, which I don't remember these from medical school, but these are probably one of the most painful procedures that an OBGYN can do for a patient. They're expensive and they're very subjective, and they really don't give us any more information. So the bottom line, the big stuff to use to tell if a patient's ovulating would be the ovulation predictor kit and the simple basal body temperature chart. All right, ovarian reserve test. This is the big buzz now in infertility, is trying to figure out whether or not the patient is too close to menopause and running out of eggs. So there's some tests that we can do in women that are over the age of 35 that have unexplained infertility, family history of early menopause, if they've had surgery, chemo, radiation, smokers, and it's to identify women that are going to have a poor response to treatment. And basically the tests are getting follicle stimulating hormone, counting the little follicles in an ultrasound just to see if they have the little follicles, and measuring anti-Müllerian hormone. So there's different tests that we can do. None of them have really been shown to be any better than the other. Semen analysis, this would be looking at the guy, obviously. And this is the WHO standards. There is a new standard out that still doesn't seem to have been adopted, because most of the reports I get back all have this. You want to see at least 2 mils of ejaculate with a concentration of greater than 20 million mils per cc. A motility, greater than 50% of them swimming forward. Morphology, 30% of them normal. And morphology, they look at like swollen heads. They got these great names for funny looking sperm. Pinheads and double tails and and all kinds of interesting names. And there's a computer-generated way of doing this, but it really doesn't show. It's not really that much better than just looking at a slide. We tell our patients that they should wait for 2 to 3 days prior to collection, and that they should masturbate into a clean container, preferably with a lid. I've seen the most interesting methods of transportation. Kleenex held by a rubber band around a jar is not a good way to transport semen. We tell them to get it to the lab within 1 hour and to keep at body temperature. Another one that used to be done, hopefully people still aren't using the hamster egg penetration test. This is where we would superovulate hamsters and get tons of eggs out of them, fertilize the eggs with the guy's sperm, and if greater than 10% of the eggs fertilized, then the guy was said to be potent. No standardization, expensive. Studies show that it doesn't work. There's no correlation with in vitro fertilization data, so the hamster egg penetration test hopefully is going by the wayside and has already gone by. All right. Looking at the fallopian tubes, chlamydia. Chlamydia, like I said, is a killer of the fallopian tubes. There's studies that suggest that they may be as accurate as surgery or looking at x-rays, but the only problem is that there's lots of kinds of chlamydia out there, and they don't target the one that we're looking for. But it may provide some information for us. The best way to look at the fallopian tubes is with a hysterosalpingogram or a laparoscopy. And this is a great test because not only is it diagnostic, but it's therapeutic. I've had a ton of patients get pregnant after getting these tests. And we look to see if their tubes are open and if their uterine cavities are normal in appearance. And you can't see what's on the outside of the tube. You can't see if they've got endometriosis or anything like that. Like I said, it has therapeutic benefits, and it's got a 60%, even if it's abnormal, there's a 60% probability that the tube actually looks okay when it shows that it's blocked. And this is a picture that I stole off of the internet, since it's got so much good stuff on it, showing a uterus, and this is the left fallopian tube spilling, and that's the right fallopian tube. Both of those are spilling dye. This is a bad HSG with the tube blocked right there with a hydrosalpinx, and left hydrosalpinx right there. And this is a patient right here that either has a bicornuate uterus or a large uterine septum that was diagnosed on HSG. Let's see, laparoscopy. Laparoscopy is kind of the last thing that we do to see if, for the infertility workup. And we do it mostly in women with pelvic pain, wonder if they have endometriosis or any kind of pelvic adhesions. Otherwise, like I said, it's the last test that we pretty much look at. And this is a picture of a normal laparoscopy. This is your uterus right here with your fallopian tubes and the ovaries. And this is one that case that I actually had this week, where this is the uterus right here, and this is the round ligament. You can't even really see, you can't see the ovaries, you can't see the tubes, you can't see anything. Actually, I take that back. You can see the tube. This structure right here that looks like bowel is actually her fallopian tube. And we looked up at her liver. I'm sure that you guys don't remember this, Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome is where they probably had chlamydia or gonorrhea, and they have adhesions up on the anterior surface of their liver going up underneath their ribs. So this lady indeed did have Fitzhugh-Curtis syndrome. So unfortunately, although this talk is about trying to do infertility without in vitro fertilization, this lady is going to need in vitro. So looking at the infertility workup, bottom line, we cut a lot of them out. It should be OST rather than COST, since none of these tests, neither of these are good. So we try to determine if they're ovulating by basal body temperature or ovulation predictor kit. We look at the sperm with a semen analysis, and we look at the tubes with an HSG and a laparoscopy. So the timing of the tests, most of the stuff that we do, we get after the menstrual period, since that's when the uterine lining is its cleanest. We get the hysterosalpingogram there, the laparoscopy there at that time. Obviously, we get the ovulation predictor kits right before ovulation, the mid-luteal progesterone level in the luteal phase, and the semen analysis we can pretty much get at any time. Looking at treatment, cervix, if there is a problem with the cervix, say that they've had some kind of cervical surgery where we've had to remove part of the cervix for cervical cancer or pre-cervical cancer lesions, they're going to get an intrauterine insemination. And what that is we take the semen, put it in a little centrifuge tube and wash it with a buffer, pour the semen out, and just re-inject the little spermy guys back up into the uterus. Ovulation, we have clomiphene citrate, which is an anti-estrogen, which stimulates FSH production. We have FSH injections, which patients can take every night, and an interesting procedure called ovarian drilling. And this is for polycystic ovarian syndrome, where we basically go in laparoscopically and punch a bunch of holes in the ovary and drain the ovary of the androgenic fluid. Sperm, we can use the intrauterine insemination, do donor, or intracytoplasmic sperm injection. And intracytoplasmic sperm injection, you've probably seen it like on Nova. Whenever they're trying to show real high-tech stuff, they're holding an egg and put the needle in and put the sperm into the egg. That's what ICSI is. In fallopian tubes, sometimes we can fix fallopian tubes. That prior patient that I was showing you, unfortunately, I don't think her tubes will be able to, I don't think we can fix her tubes. And so she's going to need the assisted reproductive technologies like in vitro fertilization. So if we look at, say we have a patient, we look, everything's okay, she's had no prior cervical surgery, she seems to be ovulating, sperm's okay, tubes look great, everything looks great, then we have unexplained infertility. And this is my last slide. And what we do for unexplained infertility, we can try intrauterine insemination, lousy results, 5%. We can use Clomid, just give them Clomid and see what happens. No benefit. We can combine the two, give them Clomid and intrauterine insemination, and some trials have shown about 10% of patients will get pregnant, which is a big improvement over the 3% that you're going to see anyway. We can give them the fertility shots with intrauterine insemination, and that used to be the big treatment, but we were telling patients they're going to have a 26% success rate until the NIH came out last year and said, nah, it may not work so well. It's going to be about the same as the Clomid and the IUI. So the big treatment is going to be in vitro fertilization, which is closer to about 40% now per cycle. But the problem with IVF is a lot of patients don't want to do IVF. It's expensive, their insurance companies don't cover it, and there's a lot of ethical issues associated with in vitro fertilization. For example, the leftover embryos. A lot of couples do not want to discard them, and they can't afford to freeze them. So IVF is a great option, but not everybody wants to go to IVF. So these other things right here are pretty much the best that we have to offer. And like I said, IVF has the best chances for unexplained infertility. And I think that's it. If anybody has any questions, I would be happy to answer them. That's been. See, now that was a question that we talked about, and that's a good question. Did we leave the hydrosalpinx in? And theoretically, it should have been taken out, because if we do in vitro fertilization, we did leave it in. There's a chance that that fluid, which could be toxic, could be leaking back into the endometrial cavity and cause problems with the developing embryos. So we left it in, and the only reason is because they said before you do anything drastic, we want to talk. So we did leave it in. Yes, sir.
You have 40-year-old unmarried women saving their eggs.
Okay, now that's a whole nother topic. Embryo or excuse me, oocyte freezing. It has been pretty much in the experimental stages, but there are sites that are doing it, where they are actually able to put like antifreeze inside of the egg and freeze them in liquid nitrogen. So it's not something that St. Louis University will let me dabble with. They won't let me dabble with in vitro fertilization. But there are sites that are starting to do that. Yes, sir. Yes, ma'am. That was, I guess that was kind of back in the early 2000s that metformin was this huge treatment, metformin for insulin resistance. Tons of studies showed that it helped with ovulation, it helped decrease miscarriage rate, it helped with fertility, but there was a big study that was published in the New England Journal that said, it doesn't do any good. But yet there was another one that just came out and said, well, wait a minute, maybe it does. So the verdict is out on that. I think most people are kind of holding off on it because the New England Journal study was a little bit bigger than the other one. I don't think there's any harm. If they can tolerate it and not get sick, I don't think there's any harm in it. No. Any other questions? Yes, Jeff.
What percentage of births, twins, and triplets, and so forth, the technologies that you use?
What is the percentage?
What would you expect if you
Well,
population induction and so forth, different things?
when we use Clomid, I quote 5 to 7%. Almost always twins. I have never seen anything more than twins on Clomid, although you hear people say, oh, I've seen quads multiple times. I've never seen it. Using FSH injections, we quote closer to 15 to 20%. And with in vitro fertilization, I don't know what the latest quotes are for IVF, since I'm not really involved with it anymore, being in a Catholic hospital. But they have dropped. When I was a fellow, we were putting up to 6 embryos back into the uterus, which, I mean, if you have 6 embryos take, then you have to have selective reduction, which is definitely a no-no in the eyes of the Catholic Church. So they would never let us do IVF at SLU, but they're now putting back fewer embryos, like 2, maybe sometimes 3. So it is getting less. Yes, sir.
Well, from the perspective of an endocrinologist, the metformin addresses a lot of the basic underlying problems in the dysmetabolic patient.
Mm-hmm.
The clomiphene doesn't.
Right.
You know, you get reduction in insulin levels because you address the insulin resistance issue. You have reduction in androgen levels, and you actually have reversibility of the acanthosis nigricans component. So there's a cosmetic benefit. The secret to using the drug is you don't start them on 3 tablets a day. You start them on 1 post-meal after their biggest meal, and over 2 to 3 weeks you titrate them up if they're tolerating it. Most patients with that kind of a regimen will get to the dose that you'd like to have them on, which is about 1,500 milligrams a day.
And I don't know why people don't do that. I have
It's
patients
simple.
came in, they said, I can't take that. I threw up. I'm like, well, how did you take it? And they'll start them off on 2,000. And I'm like, ugh, no wonder you didn't like it.
Yeah, 1 pill a day after the biggest meal, and then you want to get to the target dose. It doesn't matter how fast you get there.
No, I agree 100%. But the thing is, looking at fertility, it doesn't, the metformin plus the Clomid did not really show much more of a benefit. And I'm not arguing with the treatment of like the metabolic effects of metformin, but just as far as like the pregnancy rates and miscarriage rates, they really weren't that improved that much.
What's clomiphene cost now?
You can get it at Walmart for $4, I think, $5 for 5
It
pills.
used to be like $8 a tablet.
Yeah, it's pretty cheap now. Another pill that we're using now, which is not FDA approved, is letrozole, which is an aromatase inhibitor. Rather than being an anti-estrogen, it blocks estrogen production, and that's also come off of, that's now generic too. So that was like a couple $100. Now they can get it for $15. So the price has come down with that. The shots are still outrageously expensive, like almost $5,000 for a cycle of FSH injections. Anything else? Thank you very much.